It's Monday, live in the Element Well studios. We've been talking about a very depressing topic for the last half hour, which is the financial world. So I figure we'll turn it to something cheerful, and that's the state of medical care in the state of Mississippi. This was a bad choice, Tim. I can tell already.
You're doing back-to-backs, aren't you?
Yeah, this is not moving in the direction I was hoping it would. Tim Moore, President and CEO of the Mississippi Hospital Association. Hadn't talked to you in a while, man. How you doing?
I'm doing good, as well as we can.
Yeah, as well as can be expected.
We've got a lot going on, and a lot more that needs to go on.
Well, let's just get right into it. Okay. With everything that has happened and is still going on with this term of the legislature, if you had to give it a letter grade from the standpoint of the hospitals in Mississippi, what would you give it?
Oh, goodness, that's good. I would have to say an average. I'm going to say a C. Because there's still one big issue that we just won't address. Now, on the things that have been done, I will give an A. Because there has been some good things moving forward. Certainly speak out and appreciate the governor signing the bill that Rita Parks introduced. It was a nursing bill that addressed some reimbursement for nurses or folks that went back to nursing school and came back to work in hospitals. So that's a good thing. The governor signed that, and we very much appreciate that. Talking to a hospital administrator this morning, and one of the biggest issues still is the cost of labor, and that is not being reflected in reimbursement rates. So we continue to see decline in the financial position of our hospitals.
Well, and that has come from several different things. The pandemic certainly didn't help it.
Oh, absolutely.
But when you have a nursing shortage, you have to raise what you're paying them to be able to get them.
Absolutely.
And everything else has to keep up with that, or there's a problem.
And it exploded with the pandemic because everybody in the country all of a sudden had an even worse nursing shortage than they did before. Then it started branching over into other services, other provider categories, whether it be lab techs or respiratory therapists or radiology, whoever. Everybody was looking for somebody to fill a spot. And, of course, when supply and demand works, the wage goes up in order to fill the supply. And until you reach a point that there's no more supply to gain, and then you start looking at, okay, how do I continue these services? There's been a big talk about Singing River and OB. Didn't have the manpower to fill the service. So you have to start looking at decreasing those.
Well, it's a problem that's not going anywhere, no matter what we like to fool ourselves into thinking sometimes.
No, and then the solution is not a simple one. It is very complex. If we get to talking very much into hospital finance, and I know we don't want to go back to finance today, but if you go
Why
back
not?
to it,
You can't wet an ocean, Tim. Come on.
It is a complicated venture to try to explain a lot of times to healthcare people and definitely to lay people that don't do it every day. It is extremely complicated. And when we move one lever, it adjusts two or three things that you were not anticipating. And it's hard to really grasp that because it is so intertwined and it's so it's just simply complicated in how it all fits together to work. It shouldn't be. It shouldn't be that complicated. But over the years, it has. And of course, that's been in a lot of government intervention that has caused that and created obstacles that hospitals have to try to deal with.
And if you want a good example of just how complicated hospitals in the medical field are, if you or someone you know has been to the hospital recently, just try to read your bill.
Exactly.
It's like 12 pages long, all these line items, and some of them loop back into themselves and everything, and you just throw your hands up and go, okay, how much do I make the check out for? Because that's all you're left with.
Yeah, and the problem is that bill really doesn't mean anything. and we fight that constantly. I've been in healthcare all my life, and the biggest challenge we've had has been hospital billing. And it has been, again, the payers, the government, that's where that has come from. Hospitals did not create that monster. They would love for it to be simple. I had an administrator years ago tell me that, we're rapidly reaching the point that half of our labor force does not take care of patients. We've exceeded that now. Okay? That's part of the system that's broken.
Well, and that's part of the system that's going to be very difficult to fix.
It will.
Very much so. But that does bring me back around to the question, how do we fix this? What can we do? I mean, the hospitals can't charge more. Heaven knows. That's both for regulatory reasons and just in general. You know, some people will just stay home and be sick.
No, I think that's right. And it's not really that they need to charge more. They need to get paid for what they're charging. And that's what we see constantly in the fact that if you look at Mississippi's commercial rates and you compare them to other states, we're extremely low. Matter of fact, Medicaid pays almost as well as, on an inpatient basis, almost as well as our commercial payers. That's a problem. That's an issue. And, of course, we start saying, well, now that's going to affect us because our premiums are going to go up. Well, they shouldn't. If you look back at the bottom lines that our payers have seen over the last couple of years, there shouldn't be any rate increases. Now, certainly everything has to be risk adjusted and you have to prepare for it because you don't want the insurance companies to fail either. But when you see hospitals that are on the verge of closing and you see billion-dollar returns for the payers, then you have to question, okay, now what's wrong with this system? Something's not working like it's supposed to. And again, as complex as it is, it's hard to identify exactly what you need to do to fix that. There is no question about if you go through the whole scenario in the state of Mississippi, we have a revenue problem. You know, how do you fix that? Where does it come from? Talking to legislators, you know, we're still very fortunate. We've got 2 grant bills that are alive. The Senate and the House both have a version. They're about $83 million. And to me, that sounds like a lot of money. But when you're talking about hospitals, it's not. And you look, it costs $23 million a day to keep our hospitals operating each day. So, you know, $80 million doesn't go very far when you're looking at numbers that large. But we're very appreciative of that. We still need to bump that number up a little bit to try to get out of this hole that the pandemic really put us in. Dave, prior to the pandemic, our hospitals were running about $132 million a year in the red, collectively, aggregate. And I'm going to speak all in the aggregate numbers.
Just everybody added together.
Everybody put together. And that number exacerbated through the pandemic. And the reason for that is because, just as we talked about, the supply and demand curve ran the cost up for supplies, for labor, for all those things that go into providing that care, but yet the revenue numbers barely moved. Had it not been for the CARES money that came through, we would have seen this much, much earlier. But we've not seen an increase in the revenue numbers that equate to the high inflationary rates that hospitals have seen. So it just continues to be drug out. And certainly if we have hospitals that, you know, have good reserves, they're able to pull on those reserves for a while, but we all have to understand they don't last forever. And you will have systems that are in good shape or have been in good shape in the past that it doesn't take too long. At $23 million a day, it does not take long to eat up reserves.
That $80 million is 3.5 days.
Exactly.
You know,
exactly.
and you know, you got 27 left in the month. What are you're going to run out of Band-Aids real quick at that point.
That's exactly right.
Well, here to me is the question that strikes to the heart of this, one of them, but the big one right now. Out of all of the hospitals in the state, the smallest ones, the largest ones, in your estimate, and you may actually know the number, I don't know, how many do we have that are in risk of failing right now?
Oh goodness, that's a difficult question, and let me explain why that's so difficult. Now, the way cash flow works in a hospital, because you know we're talking about big numbers. The death of a hospital is slow and painful as we go. Look at Greenwood Floor Hospital, for example. That's a perfect example of how long things can be drug out. Because of the amount of revenue that you come in, that comes into the facility over time, you can spread out your vendors long enough and pay them a little bit and keep them happy or keep them satisfied. They're not real happy because you still owe them a lot of money. But you can drag it out for so long that it becomes very difficult to say, okay, we're going to close next week. Have certainly had some calls here lately that I've had some hospitals say that they may not make it through the summer. You know, if we look, here's a pretty good illustration. We took cost reports. The cost reports are what is filed with CMS every year by every hospital. We took the hospitals across the state, 5-year period, from 21 back to 17, and looked at the numbers. If you look at just patient care revenue okay, not the other things that they do to try to make things work, just the patient care revenue. There were 11 hospitals in the state of Mississippi that had a positive margin for 5 years.
How many hospitals are there total?
114, roughly.
So about 10%. Actually had a positive revenue flow.
That should scare you. I mean, that should scare everybody and say, look, we've got a major problem here. If we hold up a sheet, when you look, now remember now what
well,
I'm saying.
I tell you what, hold that thought because we're up against a break. You're not going anywhere. You got nothing going on, Tim.
You got me, man. You got
Tim Moore with Mississippi Hospital Association. We continue in the Element Wealth Studios on middays on SuperTalk Mississippi. President and the CEO of the Mississippi Hospital Association, Tim Moore, in the studio with us, and we're handling all of the meaty questions, I guess you would say. And I'm going to change topics. I know you were talking about something, but I don't care. It's just honesty day, Tim.
Hey, I like it. I like honesty. That's a good thing.
Too many numbers. Let's get into something else here. Got something on the C Spire text line from Mose, who said, I can't understand the Let's Expand Medicaid crowd. They reimburse at less than costs, and they think they can make up the difference with volume?
Hey, great question, and one that we do hear from time to time. And, Dave, I think it goes back to the complexity of our business and what we do. People tend to forget that about 10% of the care that's rendered in Mississippi hospitals is uncompensated. It means they don't get paid for it, nothing. So if you're able to expand the coverage or extend coverage to a group of working poor that do not have it now, that you know they have health care coverage, or not coverage, but access to health care, they're using it, just not paying for it because they can't, then you're able to recoup part of that you lost. So you, all of a sudden you have something which may be less than you'd really like to have, but it's more than you had to start with. Had somebody, we had got into this discussion the other day, and I know some folks have used the hamburger stand explanation. And the fact is that, you know, if you're going to sell hamburgers for $1 and then you're going to get paid 50 cents for another one, then how's that going to help you? Well, the point is, if you're not giving 10% of those hamburgers away, then it wouldn't help you. But if you are giving away 10%, then it does help you to pick up 50% of that loss. Now, also, think about healthcare is that if you decide to get cheese on that hamburger, you have to stop the process and say, wait, we got to call the folks that's going to pay for it and see if you can really have cheese. It's just not as simple as what we would like for it to be. You know, you go back, and I love to find retired doctors that have been out for 20 years or so, and they'll pull a bill out, and it's just handwritten, and it'll be $13.50 for the birth of a child, the delivery, you know. And that was the day and time where we really we paid for the service that was provided at a reasonable rate, and everything worked. Now we've put so many things into it. And I'm not saying they're all bad. Quality is extremely important. Education is important. The fact that we are compliant with all the regulations and requirements that are there, they're there for the patient's safety. Maybe they go overboard sometimes, you know, and it creates a lot of cost. But, you know, it's all part of a big plan to maintain the best possible care. At some point in time, even with technology, can we afford that? We have to back up and say, is it affordable? But the short answer, I went way out on that one, but it's pretty simple if you stop and think about it. And keep in mind, hospitals have to give away some services because of EMTALA. And it is required that if you go to the hospital that you have a medical screening, and if they determine that medical screening is life-threatening, they provide care to you regardless of your ability to pay. It just doesn't matter. There's not another business in the world that works like that.
Yes,
so
and
just have to keep that in mind.
That was one thing I was going to point out. For a lot of these that you give away the free care, you don't have a choice.
You do not.
Yeah, you cannot say, no, I'm sorry, you can't pay. We're not going to do anything for you. You have to, which Mose just came back and said, he just said it. It's still a loss. Yes, but I think you're missing, Mose. He said it's less of a loss.
Right.
And I think a less of a loss is better than just a loss.
Than the bigger loss. Yes.
That's the point you're making.
That's right. If you look at hospitals, and I just mentioned that 11, okay, when you dig into those hospitals a little closer, you find out they have a low margin of uncompensated care. Okay, so you've got a small number that's not paying, and then you have a larger margin of commercial payers. So it offsets that difference. Now, so much of our business has gone to outpatient now. So the focus is on outpatient. And certainly our rates have adjusted some on the outpatient side, and that, thank goodness they did. But our rates on the inpatient basis, and a lot of that is a deterrent to try to keep people out of the hospital. But, hey, if you put them in the hospital, they're not going to pay you for it. Well, sometimes you have to go in the hospital because sooner or later our old bodies just break down. We just can't help that. That's how God made us. So we wear out. So at some point we have to realize that cost is going to be there. Now, we should prevent that as long as we can. We all agree with that. Let's keep people healthy. That's the way to do it. So when you start digging into the expansion or the extension of care to another population, keeping them healthy reduces the long-term care cost in any population. If you provide care and keep people healthy, that is the least expensive health care policy you can possibly put in place.
So I take it from all of this that you would be okay with an expansion of Medicaid.
I would. I've thought about it a lot, and I think it would work well.
I got that rough impression. I wasn't sure, but I just wanted to make sure that I was there.
You know, and not just from a hospital perspective, Dave. I mean, it's a moral obligation as well. We've got working Mississippians that in some cases are working 3 jobs. They're part-time jobs, so the employer doesn't provide health care insurance. They get sick just like we do. And look, if they get sick, then they're out of 3 positions, not just 1. So we improve the workforce. We keep them healthy. We limit our potential for public health issues that can arise from people not getting health care as they need it. So there's a lot of different reasons other than just financial. However, if you look at it from an economic impact study, it's a no-brainer for the state of Mississippi to pick up additional revenue. And we're certainly excited about the revenue we have now. What's wrong with getting some more?
Well, Thomas in Greenwood has a couple of questions here. One of them, would you support the repeal of EMTALA?
You know, we've talked a lot about that, and I think we have to be careful, but yes, in most cases I would. Now, remember why we put EMTALA in place to start with, and that was to make sure that people that did not have the ability to pay would still be treated, and that they would be screened and make sure that there was nothing life-threatening. We don't want people walking out and dying on the street. I don't think that is an issue with hospitals now. Hospitals just don't let people die. I mean, we just don't do that. That's against the mission, okay, of what we're trying to accomplish. So I don't think EMTALA has the same place that it did back in the time that it was passed. That would probably be a tough one to repeal. I mean, it would be tough.
It's going to be an uphill battle, yeah.
It would be but you know, there's another component to that, is if you extended it to other sectors of healthcare. In other words, if you have ambulatory surgery centers, or you have imaging centers, or you have other places that provide healthcare services, they should be providing as much uncompensated care as the hospital is in that local area. I mean, that's a different twist, but
that makes sense.
It does. I mean, either that or, you know, we've got a trauma system in the state of Mississippi, and if you don't participate to your maximum level, you pay back into the trauma system. So it's a buyer's deal, okay? So if you don't want to be in the trauma system at all, you have a rate you pay back in. It offsets costs to the other hospitals. You could do something similar to that. If you're not going to provide 24/7 care and uncompensated care coverage, then you pay into a system that helps the other hospitals provide that. That's just a different thought.
Yeah, just a different way of looking at things, but I think that may be what it takes from all sides to meet somewhere in the middle on some of these things. Sure. and make some progress, because that's the other thing that I think we tend to forget sometimes is that just about everything, what color M&M is the best is a hugely divisive issue these days. Everything is, as Rhino has said a million times, where's the truth usually found, Rhino?
Somewhere in the middle.
Right, exactly. Somewhere in the middle.
I tend to agree.
That's just the way it works.
Yep.
So we've got to find a way to come together in the middle somewhere and at least make some progress, because guess what? Less of a loss is better than a full loss.
There you go. You know, Dave, and I mentioned earlier, I've been a conservative all my life. I mean, that's just where I was raised and how I brought up. I've also run hospitals, and I know what it takes to make that work. And you know, most of our hospitals are somewhere between the first and third largest employer in a town. If you lose them, you not only lose that employment, you start losing other employment, because large businesses do not want to go to an area that does not have health care coverage, quick access to health care. So it is an economic issue. It's just like, none of us want to go to the hospital. None of us want to have a fire either, but we maintain the fire department. We make sure it's there, and we want it to be there. We don't argue about that. We don't fuss about it. Well, healthcare is very much a similar situation. We have to have it there in case we need it.
That's exactly right. Tim Moore, President and CEO of the Mississippi Hospital Association. I always enjoy talking to you, man.
Well, thank you. I enjoy being here.
It's always a good conversation. And, before you go, my shoulder's been acting up. If you could take a look at it during the break, it'd be great.
We'll check it out.
Okay, fantastic. Thank you so much, Tim. Hopefully I'll talk to you again soon. We will continue. We'll probably get – you want to stick around and talk finance and banking some more?
Oh, I better get out while I'm ahead.
He just remembered a very important meeting that he's got to be at. We'll continue in the Element Well Studios live on middays next.